Hello, this is Every Nurse's Guide to Tobacco Cessation. I want to thank you for attending. The learning objectives for this slidecast, you'll be able to explain the health consequences of tobacco use, discuss the role of the nurse in encouraging patients to quit use of tobacco products, discuss the Centers for Disease Control and Prevention best practices for cessation intervention for tobacco users, describe 2 evidence-based practices for obtaining patient follow-through on tobacco cessation, identify tobacco cessation-related community resources for both the healthcare provider to use in assisting patients and for the patient, as well as, finally, to describe benefits of anti-tobacco legislation related to the tobacco industry. Now let's talk about the problem and what it means for us in society. Smoking-related diseases are the world's most preventable cause of death. Since the first Surgeon General's report in 1964, there have been more than 15 million premature deaths attributable to smoking in the United States. Tobacco use is responsible for nearly 1 in 5 premature deaths in this nation. This equals 443,000 premature deaths. This number of premature deaths and the cost of illness related to tobacco use creates a substantial economic toll to the nation. It is expressed in the number of lives lost and actual cost to society. 443 premature deaths represents 5.1 million years of life lost. Smoking on average reduces life expectancy by approximately 14 years. You can see on the slide that the dollar cost is approximately $197 billion lost to society. In addition, an estimated 8.6 million people suffer from chronic conditions related to smoking, such as chronic bronchitis, emphysema, and cardiovascular disease. Between 2005 and 2010, there was a modest but statistically significant decline in smoking prevalence. However, declines were not consistent from year to year and were not observed in all population subgroups. In 2010, approximately 45.3 million adults were current smokers, about 3 million fewer than there were in 2005. Let's talk about that number, 443,000 people dying, premature deaths. That represents approximately 3 jumbo jets colliding mid-air every day over some U.S. city. Let's move on to environmental tobacco smoke, or ETS, also called secondhand smoke. It does not just contribute to mortality, but also a significant contributor to morbidity, especially in children. Environmental tobacco smoke contains more than 7,000 chemicals, at least 69 of which cause cancer. According to the American Society of Clinical Oncology, it is considered the 3rd leading cause of preventable death after active smoking and alcohol use. It is estimated that more than 88 million non-smoking Americans, 3 years of age and older, were exposed to secondhand smoke in any 1 year. It has long been known that passive tobacco smoke increases one's risk for developing lung cancer. Indeed, because most cigarettes have filters, some scientists think that side stream smoke is more harmful than the smoke inhaled by the actual smoker. You see some statistics on the slide that show more deaths from heart disease than cancer. Studies show that exposure to secondhand smoke increases one's risk of coronary artery disease by 25%. And while passive tobacco smoke causes an estimated 3,400 deaths a year from lung cancer, it contributes to 46,000 cardiac-related deaths per year. It is responsible for lower respiratory infections each year, resulting in 7,500 to 15,000 hospitalizations annually. In addition, according to Hopkins, it is a causative agent for asthmatic attacks in approximately 400,000 to 1 million asthmatic children and causes 26,000 new cases of asthma each year. The impact on children in low-income families is greater and occurs even in households where parents do not smoke in the house or in the presence of the children. The link is most often related to smoking byproducts on parents' clothing. U.S. Surgeon General Carmona in 2006 report said that there's no risk-free level of exposure to secondhand smoke. Non-smokers exposed to secondhand smoke at home or at work increase their risk of heart disease by 25 to 30% and lung cancer by 20 to 30%. Nationwide, cigarette smoking among adults has declined, but it's still higher than 12% National Healthy People 2010 goals that were set by the United States Department of Health and Human Services in 2000. Since 2004, smoking rates have changed little. In 2008, an estimated 21% of adults, or 46 million Americans, smoked cigarettes, and this according to the American Cancer Society Cancer Facts and Figures. Although cigarette smoking became prevalent among men before women, the gender gap narrowed in the mid-1980s and has since remained fairly constant. As of 2010, there was an absolute difference in smoking prevalence between men and women in all races and ethnic groups. This may change in the future, however, because there are more middle school and high school girls reporting using in the past 30 days and are more likely to remain smokers. Smoking prevalence remains discouragingly high in certain populations, such as those in low socioeconomic status or low educational attainment groups. Some American Indian populations and individuals with psychiatric disorders, including substance abuse disorders, also are discouragingly high users. Smoking is most common among the least educated. While the percentage of smokers has decreased at every level of educational attainment since 1983, college graduates have the greatest decline, from a high of greater than 20% to 8% in 2010. In contrast, among those with high school diplomas, prevalence is 27%. Adults with GED certificates or high school equivalency diplomas had the highest smoking rate of 45% in 2010. Additionally, groups with a high school degree or less quit smoking at lower rates than higher educated groups as well. Cigar smoking has significant health consequences similar to that of cigarette smokers and smokeless tobacco. In 2010, 2.5% of the adult population 18 years and older were current users of cigars and had smoked at least 50 cigars in their lifetime and now smoked a cigar on some days or every day. African Americans and American Indians, Alaska Natives had the highest prevalence of past month cigar use, followed by whites, Hispanic, and Asians. In 2009, 14% of U.S. high school students had smoked cigars, cigarillos, or little cigars at least once in the past 30 days. In the 10 years between 1997 and 2007, while sales of little cigars increased by 240%, large cigar sales decreased by 6%. Small cigars are similar in shape and size to cigarettes, but are not regulated or taxed like cigarettes, making them more affordable and more available to youth. This is an important point that nurses and healthcare providers of adolescent populations should consider when assessing their patients for smoking history and cessation attempts. Smokeless tobacco products include moist snuff, chewing tobacco, snus, spitless, moist powdered tobacco pouch, dissolvable nicotine products called orbs, strips, or sticks, and a variety of other tobacco-containing products that are not smoked. Each product varies in the actual amount of nicotine released. Tobacco companies are actively promoting these products both for use in settings where tobacco is prohibited and as a way to quit smoking. However, there is no evidence that these products are effective as proven cessation therapies. Use of any smokeless tobacco product is not considered a safe substitute for quitting tobacco use because of its addictive nature. This according to the American Cancer Society 2012. In 2010, 2.7% of adults 18 years of age and older used smokeless tobacco products. American Indian, Alaska Natives, whites were more likely to use smokeless tobacco than African Americans, Hispanics, or Asians. Nationwide, in the high school populations, 15% of males and 2% of females used chewing tobacco, snuff, or dip in 2009. Data indicates that initiation of smokeless tobacco products and past month use among youth ages 12 to 17 years of age has increased significantly, primarily among boys. And sales of smokeless tobacco products are growing at a more rapid pace than cigarettes. Between 1990 and 2006, per capita sales of smokeless products in the United States increased by nearly 100%, while sales of cigarettes declined by 42%. Let's discuss the physical impact of smoking now that we've talked about the individual and social costs. Smoking is associated with an increased risk for at least 15 cancers: lung, nasal cavity, nasopharynx, paranasal sinuses, pharynx, larynx, esophagus, pancreas, uterine cervix, kidney, bladder, stomach, and acute myeloid leukemia. It also causes cardiovascular diseases such as myocardial infarction, acute abdominal aneurysms, gastrointestinal disorders. It is causative in stomach ulcers. Tobacco use can cause reproductive effects like erectile dysfunction in men, and this is an important fact to remember, especially if you work with adolescents. Tobacco use can cause cataracts. Because of the dangers that smoking causes to nearly every cell in the body, you can see negative impact on patient outcomes regardless of treatment. For instance, an oncologist's ability to treat a cancer patient optimally is diminished if the patient is a smoker. If the smoker has surgery, post-surgical wound healing is diminished. Optimal cellular health for response to treatment is compromised for all levels of treatment. And of course, there's a significant negative impact on the respiratory system, which affects patients' resistance to allergens, such as airborne pathogens or oxygen in exchange, the cellular level. If you're working with adolescents, they're not concerned about getting cancer or having heart disease, but how about erectile dysfunction? Again, I want to repeat, tobacco companies actively promote these products for use in settings where smoking is prohibited and as a way to quit smoking. Use of any smokeless tobacco product is not considered a safe substitute for quitting. Smokeless tobacco is known cause of human cancer. It increases the risk of developing cancer of the oral cavity and the pancreas. Smokeless tobacco is also strongly associated with leukoplakia, a precancerous lesion of the soft tissue in the mouth that consists of a white patch or plaque that cannot be scraped off. Gum recession, bone loss around the teeth, and staining of the teeth is another physical impact of smokeless tobacco. Smokeless tobacco used during pregnancy increases the risk for preeclampsia, a condition that may include high blood pressure, fluid retention, and swelling. It also may increase the risk for premature birth and low birth weight babies. And for men, smokeless tobacco causes reduced sperm count and abnormal sperm cells. Again, cue into the components or the impact statements that can make some effect on adolescents or your adult patients. We've established the problem. Now let's look at where we are with the strategies to address this huge public health problem. When patients have an interaction with a nurse or healthcare provider, a growing percentage of them are being evaluated for tobacco use. Anytime a patient has contact with their nurse or provider and their tobacco use is not assessed, or if interventions are not offered, these are missed opportunities to make an impact on overall smoking rates and missed opportunities to provide standard of care for your patient. You can see from this slide that our practice has improved. We are, however, still missing opportunities to intervene for our patients. Note, only 30% of smokers who see their healthcare provider each year are provided an evidence-based intervention to help them cease their tobacco use. There is substantial evidence that supports even brief interventions can be effective among many different populations of smokers. Also, according to nurse researcher Gail Roberts, 2002, most smokers want to give up smoking, and we are undermining their motivation if we do not offer to help them. Tobacco-using patients need you. An overwhelming majority of current smokers wish they'd never started smoking. 70% of smokers want to quit. According to Michael Fiore, the United States Public Health Service document Treating Tobacco Use and Dependence, he and his colleagues found that 93% of chronic smokers who try to quit resume regular smoking within 1 year. But 2/3 of these tobacco users report they want to try to quit again within 30 days. It is important to note that most smokers make several quit attempts before they are successful at quitting their habit. According to Fiore and his colleagues, the fact that 93% of smokers who try to quit resume regular smoking within 1 year is the reason why most nurses and healthcare providers do not pursue smoking cessation counseling with patients. The providers judge that it's a waste of time. It's critical that you accept that every quit attempt takes the smoker closer to being successful in their attempt to quit and to a life of non-smoking. CDC recommends tobacco dependence is a chronic condition that requires repeated interventions. A chronic disease model recognizes that long-term nature of disorders with an expectation that patients may have periods of relapse and remission. If tobacco dependence is recognized as a chronic disease, clinicians will better understand the relapsing nature of the condition and the requirements for ongoing rather than just acute care. The existence of numerous effective treatments give the clinician and patients many options should repeated quit attempts be needed. Although most clinicians are comfortable in counseling their patients about other chronic diseases like diabetes, hypertension, or hyperlipidemia, many believe that they are less effective in counseling to patients who use tobacco. As with these other chronic conditions, clinicians are encouraged to provide tobacco-dependent patients with brief advice, counseling, and appropriate medication. It is important for clinicians to know that assessing and treating tobacco use generally leads to greater patient satisfaction with their healthcare provider. Nurses, you can make a difference. Nurses are invaluable resources. According to researcher Good, nurses serving on the front line of healthcare interact with individuals and families in more health-related and community settings than any other group of providers. Moreover, nurses represent the highest volume of healthcare providers in the country and therefore present a great potential to impact smoking cessation efforts. Virginia Hill Rice in 2009 found that advice and support from nursing staff could increase people's success in quitting smoking, especially in hospital settings. Patients are more likely to quit smoking successfully with the nurse's support. On the other hand, if you don't mention it to your patients, they won't see it as important. Nurses are a great support to patients. Let's not fail our patients by ignoring their smoking habit and not offering them assistance. Let's look at some of the reasons literature says nurses don't take action before we proceed on discussing how you can intervene for your patients. Some barriers are perceived as real and others are real. Let's talk about the perceived barriers first. Nurses oftentimes don't push tobacco cessation because they feel as if they are entering into a realm where they are not allowed. They feel patients are adults and can select a behavior if they want. It's their decision and their privacy that the nurse must respect. Or they might be smokers themselves and don't feel able to suggest cessation. Let's talk about real barriers then. Lack of time and knowledge. This is significant. There is both nursing and medical literature that suggests that healthcare providers are not equipped to offer their patients effective interventions. There is now a call to consider adding these components to professional education curriculum and including counseling-related questions in licensure exams. I congratulate you for taking the step to listen to this continuing education program so that you can indeed eliminate the lack of knowledge issue as a real barrier for yourselves. These common barriers can easily be overcome. I'll be discussing 2 suggested strategies for you to use to offer your patients. If you give this attention and learn it, you'll be able to give your patient the assistance in overcoming their barriers and help them step closer to quitting tobacco use. These strategies can be implemented in 3 to 5 minutes of time so that this will eliminate both the time and the lack of knowledge barrier on your part. Let's talk about some best practices. The United States Public Health Service sponsored clinical practice guidelines treating tobacco use and dependence was developed after a systematic, exhaustive review and analysis of a list of scientific literature from 1975 to 1999. This was accomplished by a multidisciplinary team of non-federal panel of experts. This review was updated again in 2008. And I've mentioned Dr. Fiore. He was the chair of that task force. These clinical practice guidelines demonstrate that effective treatment for tobacco users exists and should become a part of standard caregiving. These guidelines encourage clinical practices to establish reminder systems within practice settings to ensure tobacco users receive tobacco cessation messaging with each visit or some level of intervention. This is simply called a provider reminder system and is considered a CDC best practice. Provider reminder systems for tobacco cessation include efforts to identify clients who use tobacco products and to prompt providers to discuss and/or to advise clients about quitting. Reminder systems can be initiated simply with chart stickers, vital sign stamps, medical flow charts, and/or checklist, and these are all mechanisms to notify the provider that the patient is a tobacco user. Providers then take action to provide counseling and resources if the patient is willing to quit. According to Hopkins' review of literature, studies show in practices where provider reminder systems are used, there was an increase of 20 to 22% of providers delivering advice to quitting, resulting in almost 6% increase in patients who actually quit for at least 6 months. The treatment of tobacco use and dependence presents the best opportunity for clinicians to improve lives of millions of Americans nationwide in cost-effective manner. This reminder system can be built into emergency room, can be built into hospital admissions, ambulatory settings like private doctor's offices, or clinic settings. Every patient should be offered a treatment. Patients willing to try to quit should be offered effective treatments, and patients unwilling to quit should be offered a brief intervention designed to increase their motivation. Let's talk about the factors that affect tobacco addiction. Treating tobacco is a complex issue. Understanding and addressing all 3 of these factors is key to a person's quit attempt being successful. Nicotine addiction is a temporary condition, but it can cause a significant amount of discomfort while it lasts. Withdrawal symptoms are usually the most intense the first 3 to 7 days, but they may continue for several weeks, although at a declining intensity. It usually passes within 4 weeks. Clearly, these symptoms are physiological in nature and can be assisted with the use of interventions of pharmacotherapies. Nicotine substitutes help allay the very difficult withdrawal symptoms and cravings that 70 to 90% of smokers say is their only reason for not giving up cigarettes or their other tobacco use. And habitual behavior can be addressed through behavior modification. It's a habit. We can modify habits. And these can be offered through most tobacco cessation programs. And it is said that habits can be changed in about 20 days. So let's look at tobacco use and apply a model that's been used to predict behavior change. The model is based on 4 components, and much has been written about this health belief model. The model says that a person will be more likely to succeed in changing a behavior if they address the components. And these components are, they have to have potential susceptibility, potential seriousness, there should be some perceived cost to them, and they should receive some cues to action. So a tobacco user must believe that they could get tobacco-related disease, and this worries them. For adults, they may get a chronic obstructive lung disease, suffer a heart attack, cancers, bronchitis, bad breath, decreased athletic performance might be considered to be serious for them. They have to believe that they can make an honest attempt at quitting. Tobacco users have to believe they can be successful. They have to believe that the benefits of quitting outweigh the benefits of continued tobacco use. They may know someone who's had problems as a result of tobacco. For adolescents, tobacco products are expensive. The perceived benefit is that they could save money, or they can afford to close the gas or whatever else they need to have to live a good life. And then finally, in the health belief model, they have to receive a motivating cue to action. This is where you come in. This motivating cue has to come from you in this situation. For adults, be sure they understand how important this is to return themselves to a state of health or not get any sicker. For adolescents, there are ways to be cool that don't have to have long-term consequences. We know for adolescents that this is a time, their youth is a time for experimentation. And tobacco use is seen as a rite of passage, and they have easy access to the products, even though it's illegal for youth to access tobacco products in all states. Help them identify ways to experiment and to show their adulthood without risking their lives. And then finally, the third factor is emotional dependence. For adults, tobacco is their best friend. This may be the most difficult factor to address because you can't touch it. It's hard to get your hand around it, but the tobacco user can feel this so critically. Have any one of you lost an important companion in life? Tobacco users are losing their best friend. The cigarette has been a support and a companion, but it's also been a crutch and a negative force. They'll go through a grieving process like anyone who's experienced loss. One point in their favor, we see a change in societal attitudes and norms. Today, smoking is less socially acceptable, and in some areas, not acceptable at all. Social dependency is slightly easier to cope with and makes for a convincing appeal to the patient. This is the time when it's important for tobacco users to prepare themselves for the supports they need to be tobacco-free. This is truly one of the strongest reasons why tobacco users benefit from attending or receiving tobacco counseling, or at least reading a self-help book. They need to know what to do in times of crisis, when they're stressed or angry, or times of celebration when they're happy and euphoric, downtime when they're bored and they don't have a lot to do, time with other smokers and users, or simply upon waking up, having a cup of coffee, or completing a meal. All of those tasks are cues to lighting a cigarette. The smoker and the tobacco user must learn what to do in place of the lighting the cigarette. Coping skills are needed to get through all these factors we just discussed, and various programs can provide the support, and the smoker needs to help to overcome these dependencies. I can't stress this enough. This is a critical part of being successful. So now that we've learned what a provider reminder system is and what resources a tobacco user needs, let's work through what to say to tobacco users depending on their state of readiness to quit. I mentioned that I was going to provide you 2 strategies to use with your patients. The first one I'm going to discuss is issued by the Centers for Disease Control. It is considered a best practice, and it's simply called the 5 A's. And this is for people who are ready to quit their tobacco use. Simply, we ask, but this should be systematically done for all tobacco users at every visit. So in the hospital, it should be part of a standard intake form. Make the assessment of tobacco use part of the vital signs taken with every visit. Same thing can apply for any of the clinical visits you may be participating in. Second, advise. Strongly urge patients users to quit with each visit. Not say, oh, it would be nice if you quit. You say, it is absolutely imperative for your health to quit tobacco use right now. In clear, strong, and personalized manner, urge every tobacco user to quit. Cutting down is not enough, and I can't tell you the number of patients that say, oh, my doctor told me just cut down my use and I'll be better. Cutting down is not enough. 3, assess the patient. Assess their readiness and willingness to quit. Ask them if they're willing to quit and make this attempt, and ask them, are you willing to do that in the next 30 days? By helping them set a time limit, you are helping them set a plan in action. And then the 4th stage, assist. You're going to assist them in establishing that quit plan. You're going to help the patients obtain support. Talk to them about getting their family, their friends behind them. Identify the friends who don't smoke, the family members who don't smoke, who can indeed give them assistance. Offer them professional support. See the community resource guide that I'll provide you. And consider pharmacotherapy, either in the form of nicotine replacement therapy or combined with other medications. And arrange, that means schedule a follow-up contact either in person or by phone. Timing is critically important, and it should occur soon after the quit date or on the quit date, preferably during the first week. Schedule a revisit in 1 month and offer the patient congratulations with every visit they make from that point on. So ask, advise, assess, assist, and arrange. The CDC also has an intervention for people who are unwilling to quit. When patients really don't want to talk to you about quitting, it's still your responsibility as their healthcare professional to provide an intervention that may move them on to the next stage of readiness. So the 5 R's are offered. Relevance. Encourage a patient to identify personal reason to quit. Motivational information has some of the greatest impact if it is relevant to the patient's disease status or their risk, family, or social situation. Do they have children in their home? Are they being the wrong role model for their children? Can they start a cost savings that they can put the savings towards vacations or college tuitions or a nice outing with a friend? 2, let's help them identify the risk. Ask the patient to list what they perceive the negative consequences of smoking. If they're in front of you in the hospital, in an office setting, many times the reason they're there is one of the risks. In acute settings, their shortness of breath. maybe they're pregnant, maybe they're infertile. For long-term risk, maybe they've had heart attack or they're having ischemic attacks. Circulatory problems, maybe they have cancer. Maybe the risk is going to be perceived for them in terms of the impact that they have on family members. So maybe the environmental risk that they have if their children are having increased ear infections, or they have a family member who had lost a child for sudden infant death syndrome. Those are the risks that mean a lot to patients. Help them establish the rewards. List potential benefits for quitting. Improved health. They save money. They can reduce the signs of aging. Their breath will improve. They won't have wrinkles around their mouth. Having them write it down in black and white. And then to see the roadblocks. Roadblocks are barriers. What do they need to overcome to be able to move them into the yes, I want to quit stage? Help them understand that withdrawal can be assisted through that, so they don't have to feel those negative physiological effects. Sometimes they know that a friend of theirs quit and they went back to smoking, so they failed it, and therefore this patient is afraid of failure. Don't let them think of it as failure. Let them think of it as one step closer to becoming tobacco-free. Maybe they're afraid of weight gain, depression. So build some physical activity in for them. Encourage them to get out and move, and that will help decrease depression, as well as it'll help them reduce the possibility of gaining weight. And then finally, repeat it. Repeat it with every visit. Repetition is an important element of this intervention. The 5 A's and the 5 R's will allow you to provide an adequate intervention in less than 10 minutes for your patient. I'm hoping that all of you will look at your time and see that that is indeed something that you can accomplish. The American Academy of Family Practitioners Tobacco Cessation program, called Ask and Act, encourages family physicians to ask their patients about tobacco use and then act to help them quit. There should be documentation and the provision of resources for quitting, and follow-up for the patient should also be planned. So if you look at it, I believe you're going to see that it has the same elements as the 5 A's. It's just consolidated into 3 different steps. Asking demonstrates your interest in the patient. You ask about tobacco use, and you ask them if they're ready to quit. After you assess them, you take the action and assist them with resources. The resources you're going to provide them are guides and or programs that where they can get the assistance to build up the inner strength and the assistance to build up strategies to overcome barriers or roadblocks. These resources are going to be provided for you shortly. And then finally, follow-up. Set the appointments for a return. Make follow-up calls to track their success and offer congratulations. Before we move on to some resources, I do want to talk about a comprehensive tobacco prevention program for adolescents. This is where the community and especially the schools come into play. The CDC strongly suggests there's no option but to provide tobacco-free school environments, and that prohibition of tobacco products on entire campuses and at all school-related events be maintained. Students should face consequences for violating this prohibition, as well as adults, including parents, teachers, and coaches. In addition to that, the CDC recommends that there be an evidence-based curriculum. Ideally, this curriculum would address the national standards for health education and include tobacco use prevention topics, and that health education teachers should receive professional development on tobacco use prevention. And then finally, there should be a link to community-wide programs for the students and families where they're provided information on tobacco avoidance and readily available access to media messaging encouraging tobacco use prevention. I know that every community is different in terms of resources. This is an area where you can become active in reaching out and becoming a leader in your community to ask for more funding for media messaging to encourage tobacco use prevention, and ask the school board to ensure that the health education curriculum is strong and addresses tobacco use prevention topics for students, and that teachers are provided the training they need to be able to implement that. Let's talk about success rates. The chart before you will list some options, but before that I want to talk about cold turkey success rates. Cold turkey means the tobacco user just drops the use of their tobacco product and never looks back. That success, it ranges anywhere from 4 to 10%. Self-help gives 12% success rate. And the difference between cold turkey and self-help is that the person makes a plan and they actually do some research to find some supports and maybe a guide and walk through, encouraging them to set a plan to involve the family support, setting opportunities to overcome barriers. And that's what we mean by self-help. There is a strong dose-response relationship between the intensity of the tobacco dependence counseling and its effectiveness, meaning the more time you have with treatment or intervention, the more success the person should have in their quit attempt. Treatments involving person-to-person contact, like telephone counseling, are consistently more effective, and their effectiveness increases with the amount of time. The addition of pharmacologic agents increased success rates from 17% or near 17% that you see with individual counseling to up to 35%, depending on which intervention is used. Nicotine replacement and tablets falls into two categories. The nicotine replacement therapy provides an alternative form of nicotine to release symptoms of withdrawal in a smoker or a tobacco user who is abstaining from tobacco use. Each type of NRT vary in speed and quantity of nicotine delivered into the circulation, but none delivered nicotine to the circulation as fast as that of an inhaled cigarette smoke. NRT, or nicotine replacement therapy, it can be found in gum, patches, lozenges, spray, and inhalers. All can be purchased over the counter except the inhaler. For that, there is a prescription required. All are equally effective, and all have been found to help improve the success rate of quit attempts. According to Dr. Hurt, the professor of medicine and director of Nicotine Dependence Center, Mayo Clinic, one should use higher nicotine patches for heavier smokers. The safety of nicotine replacement products is underscored by the fact that the patch and gum initially were sold by prescription, but now available without a prescription. For people who are heavy smokers and heavier bodies, could use higher nicotine patches for relief of the withdrawal symptoms. Conversely, a very thin person, one who might be cachexic or undernourished for whatever reason, probably will get too much nicotine in one of the higher nicotine patch doses. So they might want to start out the middle range. Okay, let's talk about tablets. Bupropion is an antidepressant with a dopamine-like action, and it's effective for smoking cessation when combined with counseling. These medications are not recommended to be used for treatment if the patient is not entertaining counseling as well. Like nicotine replacement therapy, treatment with bupropion doubles smoking cessation rates as compared with placebo treatment. Bupropion lowers the threshold for seizures, however, and is contraindicated in patients who are at risk for seizures. Treatment with both bupropion and nicotine patches are safe and highly recommended by Dr. Hurt, who I mentioned runs the Nicotine Dependence Center at Mayo Clinic. Varenicline is the newest drug on the market for the treatment of tobacco dependence and tobacco addiction, and it has shown significant positive impact on successful quit rates. It has a 48% 12-week quit rate in one study. There are some side effects with the use and therefore should be done with physician monitoring, but patients have reported disturbances in sleep, unusual dream patterns, some suicidal ideation for the more serious side effects. NRT and other pharmacotherapy has been used in adolescents and actually shown a positive impact, but there haven't been any long-term studies to prove overall effectiveness. So if they are used for adolescents, there should be tight follow-up with the clinician. We wouldn't have a complete discussion of interventions if we didn't address the possibility of relapse for those attempting to quit. We don't give up trying to control hypertension in patients or take additional steps to help patients manage diabetes more tightly. Remember, tobacco use is a chronic condition. We therefore can't give up on a patient who wants to be free of their smoking habit, but who has not had a successful quit attempt. With every patient visit that follows, tobacco use should be explored. For those who are still quit, offer congratulations. If they have started use again, offer encouragement and go back to getting them on their way. Start with the 5 A's. If they are reticent, go to the 5 R's, or ask and act, but get them to move on and help them set another quit date. It's important to note that it takes multiple quit attempts to achieve freedom from tobacco use. Electronic cigarettes are marketed as an alternative to tobacco products, and they're marketed as harmless. However, the researchers at the University of California, Riverside, evaluated 5 e-cigarette brands and found design flaws. They were concerned with their lack of labeling and also concerned about the quality control and health issues related to the byproducts. They do feel that the e-cigarettes were potentially harmful and urged regulators, meaning the FDA, to consider more studies or to actually remove them from the market. To date, they have not been removed from the market, but there is still concern over the way the product burns the nicotine, along with the compounds present in the cartridge. What happens when the nicotine is heated, but does it contain chemicals and toxicants created by tobacco combustion? Nothing is known, however, about the chemicals present in the aerosolized vapors emanating from those e-cigarettes. So the plan is for FDA to further study, and in September 2010, they did issue a statement that they were going to establish guidelines, but to date those guidelines have not been set. Just recently, however, in summer 2012, the European Respiratory Society in Vienna, Professor Gratzu and her team revealed their discoveries regarding a study to determine what the short-term effects of e-cigarettes use might be on different individuals, including people that had no known health problems. What they found was that the use of e-cigarette caused an instant increase in airway resistance that lasted for up to 10 minutes in the majority of participants. A significant increase was found in non-smokers, regular smokers and patients who had active COPD and asthma patients. So that increase in airway resistance was found in all people. Their research helped them to understand how the product could be potentially harmful. They found that with the immediate rise in airway resistance in their group participants, but they suggest that e-cigarettes can cause immediate harm after longer term use. They do say that more research is needed to understand whether the increased resistance has any lasting effects in long term, but they do recommend that effective smoking cessation treatment guidelines based on clinical evidence be used instead of advocating for the use of e-cigarettes. We've just discussed the strategies to help tobacco users quit. Now let's talk about resources that are available to help you and to offer your patients. Materials that you'll see at these different sites are written at various reading levels and available for reading online or can actually be printed out. The American Cancer Society has a toll-free number, 800-227-2345. People on hand 24 hours a day to offer information and to offer guidance on resources that are available in the caller's individual home area. There's a website, cancer.org, the American Heart Association, heart.org, the American Lung Association, lungusa.org, all have various programs online and in booklet format. You'll see the first resource on the list is a guide to smokefree.gov and a quit line, which is a nationwide quit line number. Quit lines are staffed by trained cessation experts who tailor a plan and advise for each caller. Many states have funding for free quit lines, and calling a quit line can definitely increase your chance for successfully quitting. I do want to call your attention to the resource listed under the American Legacy Foundation. It offers a program called Become an X. The X Plan is a free quit smoking program that will help your patient relearn to live without cigarettes. Before they actually stop smoking, they'll be shown how to deal with various things that trip them up. With this program, they'll be able to be more prepared to quit and to stay quit. Whether this is their first attempt at quitting smoking or their 10th, the free X Plan offered by the American Legacy Foundation can help them become non-smokers. The nice thing about X Plan is they have an iPhone app and they has an online community of ex-smokers where they can start to support each other in their quit attempt. The resources for professionals are, if you'll remember, there's the Guide for Treating Tobacco Use and Dependence, the 5 A's, and that is found at the surgeongeneral.gov. The American Academy of Family Physicians Ask and Act Tobacco Cessation Program, very thorough, very complete program at aafp.org. And again, the American Cancer Society has professional level information and also in sending you a supply of materials that you can have for your patients in your office. The other, of course, are American Heart Association, the American Lung Association, and the University for Wisconsin Center for Tobacco Research and Intervention. It offers a tremendous amount of supportive materials for both the patient and for you as the professional. And this site is run by Dr. Michael Fiore, who headed up that team of investigators. In this slidecast, you've heard discussion on the significance of tobacco use. You have heard compelling information that is supported by science on the need for and the impact tobacco cessation interventions at the clinical level can and do make a difference. Insufficient time and knowledge level are cited as barriers for not taking action with tobacco use. The scientific data and information provided in this presentation can and will prepare you with significant and sufficient information to overcome those barriers and allow you to reach out and become involved. Tobacco cessation improves life and prevents death. Be part of the solution and be sure that the providers address tobacco cessation with every visit, and you can make a difference and make sure that happens. Now, I want to encourage you to set the pace for the providers in your community, help establish a standard of care, and be complete in your treatment. Now, let me take just a minute or two to talk to you about the war against tobacco companies. We're up against an industry that with tremendous resources and a powerful lobby in Washington at all state levels. This industry infiltrates communities with support of the arts and music venues within Hispanic and African American communities especially, to ingratiate themselves with these groups. Tobacco industry spends hundreds of billions, that's billion with a B, to help make tobacco a choice for youth and individuals around you, your patients. Political action is needed to win this war against tobacco companies. One of the most important ways is to increase taxes on tobacco products. When prices rise, the demand for cigarettes decrease. An increased tax increases the overall cost of the cigarettes. Low-income smokers are more price responsive than high-income smokers, but the low-income smokers also usually represent the lower educational attainment, and those are the largest group of smokers and can be assisted by an increase in tobacco tax. And also the youth. Higher cost of tobacco products reduces the initiation of tobacco use. Children are 2 to 3 times more responsive to price changes than adults. Another political action that's critically important is smoke-free public places. In October 2011, there were almost 4,000 municipalities who had passed smoke-free legislation, and that occurred in about 35 states, including the District of Columbia and many of the possessions of the United States in Northern Mariana, Puerto Rico, American Samoa as well. Currently, about 80% of the U.S. population is covered by a smoke-free policy or provision in workplaces to some degree. Some are not as strong as others, and they do need some more work. Reduce worker exposure. They increase quit rates, decrease daily consumption, decrease employer cost, and actually have been shown by scientific study to decrease acute myocardial infarction. In addition to the 2 types of political action we've just talked about, increasing taxes and increasing smoke-free environments, there are some areas of the country that have undertaken some very innovative actions. For indoor air, there are some places in the nation that are making it against the law for a person to smoke in a car if a child is present. There are apartment buildings that are totally smoke-free. This is usually not mandated by a municipality, but by a owner of a building. The other area that is definitely federally controlled is there is the move to increase product regulation. In 2009, the FDA was transferred control of tobacco products, and since then they have banned adding flavors to cigarettes, restricting youth access to this tobacco product. They've banned misleading advertising which claimed to communicate products were more safe, or they established new smokeless tobacco warning labels, issued new cigarette warnings, and issued regulation on language that can be used on cigarette warnings. And it's important that they increase the regulation on products, especially and those including cigars and the cigarillos. The scientific community feels FDA has the potential to issue standards appropriate for the protection of public health, including those that will regulate the products to make them less addictive and less harmful. The last point I want to stress is that there is a move to extend smoke-free public place laws to other public spaces like sidewalks, parks, and beaches. If all public venues prohibited smoking, only homes would be locations where smokers could smoke. The impact on smoking prevalence would be substantial. Additionally, smoking in homes has become increasingly off limits, so smokers will have fewer and fewer locations where they might be welcome to smoke. These are not the norm right now, but there is action in the nation with these kind of measures, so I wanted to bring them to your attention. Following is a list of resources I used to prepare this presentation for you. I hope you'll find them informative and that you'll step forward to help your smoking patients and help with this fight against big tobacco. Thank you very much. I hope that you found this beneficial and will be moved to help your patients and your community. Thank you.
To earn continuing nursing education credit, please click the Next button at the top of your screen.